Welcome to IST. Today we are discussing about imaging in toxicology. Now my topic is what are the imaging techniques can be done in emergency room to diagnose and manage toxicological cases. First case is a 30-year-old male patient presented to emergency room with OP compound poisoning, treated with atropine and palm, that is a standard line of treatment. Now, after 3 days, he is having severe cough and lung crepitation. It can be due to aspiration pneumonia or ARDS. Patient is having fever, maybe due to atropine or the lung inflammation. He is having difficulty in breathing and altered mental status. It can be due to toxic encephalopathy or due to atropine itself. Now, X-ray is taken. X-ray shows bilateral diffused infiltrate, especially in the lower zone of the lungs. It is due to either aspiration pneumonia or due to ARDS. ARDS is one of the common presentation of OP poisoning. Now the CT shows toxic encephalopathy features. There is hypoattenuation on both sides of brain, especially in the basal ganglia. This patient can be treated with atropine infusion and pralidoxime. These are the standard care of treatment, and supportive therapy like mechanical ventilation all may be required in this patient because the patient has gone to ARDS. Next case is a 18-year-old female patient admitted with large dose of Paraquat poisoning. She was treated with supportive therapy, IV fluids, antiemetic, H2 blockers. She had severe oral pain, mouth ulcers, neck swelling because of the edema and inflammation. Lot of ulcers over the tongue, palate, lips, and oral bleeding also there. It's a typical presentation of Paraquat poisoning. And on X-rays, you can see bilateral diffused infiltrates. They are actually lung fibrosis, interstitial fibrosis. This is a classical presentation of Paraquat poisoning. And when we treat the patient with oxygen, this problem can be aggravated. So, early unwanted oxygenation should not be given in this type of patients. But however, during the late phase of the lung infiltration or lung fibrosis, patient may require oxygen. CT confirms this diagnosis. There is interstitial fibrosis. Patient should be resuscitated like any other patient. Standard care should be given. Airway, breathing, circulation should be taken care. Main treatment is hemoperfusion. That should be given for this patient. Anti-inflammatory immunomodulators can be given. Dexamethasone can be given. That's a steroid that can be tried to prevent this fibrosis. Antioxidant therapy like N-acetylcysteine can also be given. Here another case, a 22-year-old medicine trainee admitted into the hospital with intravenous injections of elemental mercury. You can see the bright spots on the hand in X-ray. They are mercury extravasated. When the patient takes IV mercury, it may reach to the lungs. You can see in the X-ray lungs there is bright spots throughout the lung fields. Whereas now on the opposite side, you can see a patient who had consumed mercury orally. On abdominal X-ray, you can see these bright radio opaque material. So that's classical of mercury poisoning. Treatment for mercury poisoning is dimercaprol or succimer. That is a standard line of management. Dimercaprol deep IM should be given for 5 mg deep IM followed by 2.5 mg per kg 1 to 2 times daily for 10 days. Succimer 10 mg per kg dose every 8th hour for 5 days. So that is the standard therapy for this condition. Now after treatment of injection of mercury, after a few days of treatment, you can see the X-ray. There is complete clearance, but there are still some bright spots in the lung fields that may not create any problem for the patient. We'll see the next case. 25-year-old lady consumed 200 tablets of iron, ferrous sulfate. So that's a very high dose, but we'll see what type of investigations are required in this patient. So patient is hemodynamically stable. So we could take an X-ray abdomen. You can see lot of radiopaque tablets in the abdomen. There is a classical picture when we take iron tablets. After treatment, like patient had emesis from home and whole bowel irrigation was given, and the second radio shows very few, 1 or 2 tablets only, the stomach. So that is the X-ray finding seen in patients who is having iron tablet ingestion. So it's a radiopaque substance. Now we'll see the treatment. Treatment of iron ingestion is defuroxamine. IM for patients who are not in shock. Start 1 gram IM initially, then 500 milligram 4th hourly for 2 doses. If the patient is in shock, 1 gram slow IV infusion. Rate of infusion should not exceed 15 milligram per kg per hour. So that's a dose. Iron overdose, the treatment is defuroxamine. We'll see next case. It's a male child admitted to pediatric emergency department with acute abdominal pain, vomiting, severe constipation. This patient had history of pica, of ingestion of flaking, paint and pencil leads. This is one of the classical presentation of lead poisoning nowadays. Children eat pencil leads. Now most of the paint brands, they do not contain this lead. So lead poisoning from painting is not very common nowadays, but pencil leads can create problem, especially in children. We'll see what happens in this patient, what is the type of imaging you can see. We'll be doing blood level test for all these type of patients, but we are discussing about imaging. We can see the X-ray here, X-ray knee, that shows dense metaphyseal bands. That is a strong evidence for lead poisoning, but this is not only seen in lead poison, this can also be seen in other types of heavy metal poisoning, vitamin D overdose, healing stages of leukemia, rickets and scurvy. So metaphyseal bands are classically seen in lead poisoning, especially in children. These patients may require treatment with succimer or EDTA. Now, chelating agents are used in many types of poisoning in emergency room or in medicine wards. You can see here lead, iron, aluminum, cyanide, arsenic, mercury, copper, all these things we have chelating agents that can treat this type of conditions. We are not discussing details of this type of treatment here. We are discussing mainly radiological features of the acute poisoning. Now we can see the next case. A 26-year-old male presented with 24-hour history of pleuritic chest pain. This is a recent case we have seen after cocaine insufflation. He is a smoker, he is an alcohol user, he also takes cannabis. CVS and respiratory systems are normal. ECG shows sinus rhythm, ST elevation in inferolateral distribution. So ST elevations can be there in this type of patients. He is having severe retrosternal pain. One chest X-ray was taken. We'll see what happened to the chest X-ray. Chest X-ray shows a thin rim of air on the left side of the heart and on the left dome of the diaphragm. So that is pneumomediastinum. It's mainly seen in cocaine users. It can also be seen in many patients in ICU where there is central line intubation, all these things. It is due to barotrauma during the insufflation process. Cocaine can also cause bronchospasm. It can increase the alveolar pressure that further increased by forceful snorting. So that's a complication which is commonly seen in cocaine abusers. Pneumomediastinum. This patient may not require much treatment for the pneumomediastinum. That takes time to heal. So we have to wait. Another case is 19-year-old woman unknowingly ingested cyanide and she was brought to emergency department. She is in unresponsive state. She is in shock due to severe metabolic acidosis. She had headache, anxiety, confusion, vertigo, seizures, and she became comatose. And now she is admitted to ER with shock. We will see what type of imaging is useful in cyanide poisoning. So we can see here the brain imaging shows basal ganglia lesions. So patient is having bilateral basal ganglia lesions, especially the striatum, cerebral cortex, mainly in the sensory motor cortex. So hyperattenuation can be seen in basal ganglia. It's a classical picture seen in conditions like carbon monoxide poisoning, methanol poisoning, and cyanide poisoning. So this patient is admitted with cyanide poisoning. CT, we may not get time for CT scan and all, but CT shows this picture. Now the treatment for cyanide poisoning is sodium thiosulfate 12.5 gram with hydroxycobalamin 70 milligram per kg body weight. So these are the two important treatment aspects for cyanide poisoning. Now another case with methamphetamine abuse. 20-year-old male was brought to emergency unit in a comatose state after methamphetamine abuse. Before presentation, he experienced 3 episodes of seizure, palpitation, and altered behavior. He is having a very low blood pressure. Systolic BP is 60 only, pulse rate is 120, respiratory rate is 30. We'll see what happens to his CT scan because of methamphetamine abuse. Extensive temporoparieto-occipital infarction, that is seen in this type of patients. Mechanism of methamphetamine associated stroke includes hypertension, vasculitis, direct vascular toxicity, and vasospasm. So this patient is having extensive stroke. With the stroke you can see in the black color, temporoparietal occipital infarction. That is classical picture seen in methamphetamine induced stroke. Now another patient who is a 30-year-old alcoholic male patient admitted with altered sensorium. He had taken binge alcohol intake 6 hours prior to the presentation. Both alcohol and methanol will have similar presentation. Both will have acidosis. That's why patient is having Kussmaul's type of breathing. Neurological examination reveals GCS of less than 11, that is low. So this patient had consumed methanol poisoning. Patient can have acidosis, visual loss, all other classical findings seen in methanol poisoning. We'll see what happens in MRI. MRI shows hemorrhagic putaminal necrosis. That's a classical finding you can see in patients who is having methanol poisoning. Clinical findings will be visual loss, altered behavior, seizures, and severe acidosis. Most of these patients may require dialysis initial itself because the acidosis will not be able to correct the acidosis. Formiprazole can be given 15 milligram per kg in 100 ml 5% dextrose over 30 minutes followed by 10 milligram per kg IV 12th hourly for 4 doses is the treatment of choice. Ethanol also can be given. Loading dose 10 ml per kg 10% ethanol in 5% dextrose IV over 30 minutes. These are the drugs of choices in methanol poisoning. Now another important aspect of toxicology in emergency room is body packers. Here you can see a patient who had severe abdominal pain and vomiting one day after arriving from Colombia. So whenever we have abdominal pain, normally we can take X-ray abdomen, or we can go for CT itself. If the pain is severe, X-ray does not reveal anything, we may go for CT scan. Here the CT is taken. You can see bowel obstruction is there, and the patient underwent laparotomy because of this bowel obstruction and removed 15 packets of some material, unknown material, from the stomach, intestine. That has created bowel obstruction. Body packing refers to internal concealment of drugs within the gastrointestinal tract or other orifices. Person who does this may be called as body packer. Drugs also can be concealed within the condoms, foils, latex, cellophane. So when we take an X-ray, we can get various findings, but most important finding is always intestinal obstruction with some foreign material in the abdomen. So there are two important signs, double condom sign and Rosette sign. Double condom sign is surrounding air rim or halo from air within the packets. Rosette sign is air trapped within the tired of end. So these are the two important findings, but when we see the X-ray, we can see some objects in the intestine, and patient will have abdominal pain or intestinal obstruction or constipation, something related to abdomen. So these are the common presentations in a toxicology case in emergency department. But when we discuss about various aspects of toxicology, there are a lot of imaging findings you can see, especially in stable patients who takes chronic toxic material or postmortem findings. Various aspects of imaging is there in related to toxicology or forensic medicine. I have only covered uh, problems related to emergency medicine department. We have discussed about various aspects of imaging in emergency room for toxicological cases and their management. Thank you.